Okay, let's change subjects slightly here. And do you guys feel that there's an opportunity to give this a kind of treatment in an outpatient or a community type setting rather than the intense university BMT programs that most of us are all affiliated with? Fred, what do you think?
So as we know, CAR T cell therapy can lead to cytokine release syndrome and neurologic events, and those toxicities can be very severe. With the different CAR T cell products, we're seeing that the rates of those severe toxicities can be different. But I do believe that centers that administer CAR T cell therapy need to have a minimum knowledge of how to manage those toxicities and be comfortable in the inpatient side and rapidly admitting patients to the inpatient side when those things happen. And in my experience, we do outpatient CAR T cell therapy. You actually need more infrastructure at a center to administer outpatient CAR T cell therapy than you actually do to administer it inpatient, because you need to have the clinical setting where you can see a patient frequently, and you have the providers who are vigilant and there to see the patient at a moment's notice when they do get sick.
And on top of that, I think we all are at incredibly busy centers where our capacity, our inpatient capacity actually exceeds the number of inpatient beds. And so we find there's an insurance policy to electively admitting a patient for their CAR T cell therapy because we can plan that. It's the unplanned admissions that we have a really hard time, and sometimes it can take patients 12 to 24 hours to get a bed if they're coming in an unplanned way, and we have to create the infrastructure to circumvent that, which is one of the holdups that we've had at our institution.
But I think we have some efforts to stratify our patients. We know the patients who are at risk, or the ones who are very low risk patients. We alluded to that: low tumor burden, less inflammatory state. Those are the patients that predominantly could be an outpatient, whereas the high risk patients with high tumor burden, those are the ones we really would look to keep in straight away.
Well, I know that at our center, we have a considerable outpatient experience now with the lisocabtagene maraleucel, where I think I've treated all of the patients in the outpatient setting. But I've also treated quite a few patients with the tisagenlecleucel in the outpatient setting. I've not treated anybody with axicabtagene in the outpatient setting, and they stay in the hospital. But we saw at this meeting also emerging data with lisocabtagene maraleucel from some of both the trials that were presented and the pilot study, which was as a study in patients treated largely in community centers as well as academic centers. And a lot of those patients were treated as outpatients, and they were at an earlier stage in their disease, first relapse in some cases, transplant ineligible. And I think that the data we saw was that in those patients that could be treated as an outpatient, many of them actually stayed outpatient. But I really want to echo Fred's comments that to do this as an outpatient, it's really dependent on the center. It's not necessarily just the product. I think some products are more easily done in the outpatient setting. The 4-1BB constructs have a later onset. You can get to day 4 or 5 before they have to be admitted, and there may be major advantages, as you said, about reimbursement for this. But also just the incidence of cytokine release syndrome, which being less than half of the patients, also is conducive to keeping those patients as an outpatient. And I think everyone's quite excited about that. But it does require a team. You have to have 24/7 triage. You have to have 24/7 ability to directly admit the patient to the hospital. I think ideally they don't go through an emergency room. They have to go to a team that knows how to take care of them. They have to stay within 30 to 60 minutes of the center, and they have to have a qualified caregiver with them that can at least call 911 or call the center to get them in at the first fever. Encouragingly, we saw that fever was the most common reason, and most of those people didn't require escalation of care once they got to the hospital.
So correct me if I'm wrong, but the pilot study actually mandates that all patients be treated outpatient, and I think it's like 17 or 18 centers, the majority of which are actually community centers that have not participated in CAR T cell therapy before. Is that right?
Yes, but I think that there's a big vetting of those centers, and they essentially have to qualify for many of the things that you would have to do for FACT accreditation, although it's not FACT accreditation. Because if you think about it, there still are a number of issues, chain of custody, right? From the apheresis to the chain of custody to getting the cells back having the standard operating procedures to treat CRS and manage patients, and then having all the procedures. So I think it's, even if these are, quote, community, they're high-level community centers.
Yeah, I think it's clear that administering CAR T-cell therapy in the outpatient setting and keeping the patient out of the hospital is desirable for many reasons, but to do that, bottom line, you have to have some significant infrastructure. And in fact, accreditation would sort of prove that, but it may not be the only way. But I think as more CAR T-cell therapies come online, it's just important to understand that they're probably going to still be utilized at larger referral centers as transplant is. And that doesn't mean there won't be smaller programs that pop up, but there has to be infrastructure around that.
But I think one of the big problems we have is we're not treating everybody who's eligible for this disease, right? The estimate is somewhere the 10 to 20% range that we're actually reaching. And I know for a fact where I am in Seattle, for example, patients from Montana, a lot of them, they don't want to go more than 30 minutes from their house, and so that's clearly we may need to not just do it in the major centers, but develop these closer to home approaches, and maybe some of these products will be more conducive of that. Max, you mentioned that you kind of choose patients who you're going to do outpatient or not based on characteristics. I mean, we personally don't, and we have treated people who I would think even who are quite sick and very high risk, because it's not 100% predictable whether they're going to get into trouble. And even then, they may not get into trouble for 4 or 5 days later. So I think if they do have good caregivers and they do have a situation where you have a great team, then you might be able to do this. But it's not for everyone. That's absolutely
Totally agreed. It's all experience, and you have to build up that experience, and then you can start to move it out into the outpatient situation. Completely agreed with that, David.
Right. We've treated 300 plus CAR T-cell patients, and to date have not done outpatient because primarily axi-cell, but also the infrastructure on the outpatient side, as Karen mentioned, to move to the inpatient side is daunting. And so I think the idea that this can be done outpatient at community centers, ideally those that already have done inpatient and have the knowledge to do that, because I think the patient selection, it would be great if you could decide who you can treat in Montana and not send to Seattle. I think that's tricky.
Also, there's a learning curve, right? I mean, remember back when we first started doing CAR Ts, I mean, we definitely had we had to learn our way in the management. And even the first few times you see this, cytokine release syndrome can be pretty scary. Neurologic toxicity even worse.
I remember the first patient, we treated the first patient on the Zuma 1 trial, and it was quite scary, seeing that patient, and you needed to see a few patients and have a few reps before you really felt comfortable.
I think that for sort of a standard CAR T-cell course, treating a handful of patients is sufficient. But now we are 3 years into treating patients with CD19 CARs, and I still, on a sort of 3 or 4 times a year basis, see something that's totally shocked me and is totally new, and things that I still can't explain, right? So I think that this is we're at the tip of the iceberg here a little bit in terms of what we have to learn.